Assalamu alaikum wa rahmatullahi wa barakatuh. Hello my daughters and sons. Today we will continue with chemotherapeutic agents. In the last or previous lecture we discussed what's the meaning of chemotherapeutic agent and how can I classify chemotherapeutic agent according to spectrum, according to the effect on bacteria, according to the mechanism of action. And we know that there are four mechanisms of action of chemotherapeutic agent or antibacterial chemotherapeutic agent. Antibacterial act on cell wall senses, they inhibit cell wall senses, and antibacterial that disturb plasma membrane permeability, and antibacterial that act by inhibition of metabolic pathway, and antibacterial that inhibit DNA synthesis. And we first discuss the first group, the antibacterial agent that act by inhibition of cell wall synthesis. We begin with Betalactam chemotherapeutic agent, and this Betalactam include penicillins, Cephalosporins, Carbapenems, and the monobactams. We discuss penicillin, pharmacokinetics, and classification of penicillins. We classify penicillins into four groups: natural penicillin, broad spectrum penicillin, penicillinase resistance penicillins, and anti-pseudomonal penicillin. Today we will complete this group. We will complete the antibacterial agent that act on cell wall synthesis. Antibacterial agent which inhibit cell wall synthesis. Cephalosporins, the second example of beta-lactam chemotherapeutic agent. They are classified into four groups: first generation cephalosporins, second generation, third generation, and the fourth generation cephalosporins. First generation include cephalexin, cefadroxil, and cefardine. They are acid stable, they can be given orally. They are highly active against gram-positive bacteria with low activity against gram-negative aerobe and anaerobe. And so they have narrow spectrum. First generation cephalosporins, they are acid stable, they have narrow spectrum, and they are beta-lactamase sensitive. They can be easily destroyed by beta-lactamase, and so they can't treat beta-lactamase producing in bacterial cell infection. The second generation of cephalosporins include cefuroxime, cevaclor, and cefotitan. Cefuroxime, cevaclor. They can be taken orally, and so they are acid stable. They have the same spectrum against gram-positive bacteria, but they show increased activity against gram-negative bacteria. So they are more active against gram-negative bacteria when compared with first generation cephalosporins. They are active against gram-positive and gram-negative bacteria, but they are not active against Pseudomonas resistant bacteria. They are beta-lactamase resistance. They can pass blood-brain barrier and reach keep effective concentration in CSF, but not all the member, only cephalosporin. So I can't use second generation treatment of meningitis. First generation cephalosporin, cefalexin, cefadroxil, cefardine, they are beta-lactamase sensitive, they are acid stable, they have narrow spectrum, they active against gram positive and low activity against gram negative. Second generation cephalosporin, cephaloxime, cefaclor, they are acid stable, can be given orally, they show increased spectrum, they active against gram positive bacteria and active against most of gram negative bacteria, but not Pseudomonas. They are beta-lactamase resistance, so I can use them in treatment of beta-lactamase producing bacterial infection. They can cross blood-brain barrier, but I can't use them in treatment of meningitis. Third generation cephalosporins, cefotaxime, cefotriaxone, and cefopriazone. They all acid labile. They all can be destroyed by gastric HCl, so I can't use them orally. All are used parenterally. They are highly active against gram-negative bacteria, including Pseudomonas, but with low activity against gram-positive ones. So their activity against gram-negative bacteria become higher when compared with first and second generation, but their activity against gram-positive bacteria become low. They are beta-lactamase resistance, so I can use them in treatment of beta-lactamase producing bacterial infection. They cross blood-brain barrier and reach effective concentration in the CSF and are preferred drugs for treatment of gram-negative bacterial meningitis. So, third generation, acid labile or labile, they can destroy it by gastric HCl. I can't use them orally, only by injection. They active against gram-negative bacteria, including Pseudomonas. They are beta-lactamase resistance. They can cross blood-brain barrier and I can use them in treatment of meningitis. Fourth generation cephalosporins, Cevibeam. Cevibeam is acid labile, can be destroyed by gastric HCl. I can't use it orally, only parenterally. It is similar to the third generation, but with more activity against Pseudomonas and more resistance to beta-lactamase. So, fourth generation of cephalosporins, from first to fourth. First generation, acid stable, can be given orally. Beta-lactamase sensitive, they can be destroyed by beta-lactamase. They have narrow spectrum, active against gram-positive mainly. They can't cross blood-brain barrier. Second generation, they may be, or most of them can be given orally. They are acid stable. They are beta-lactamase resistance. They are active against gram-negative bacteria, but not Pseudomonas. I can't use them in treatment of meningitis. They can cross blood-brain barrier, but in not effective concentration, except one of them. So I can't use them in treatment of meningitis. Third generation cephalosporin, they are famous generation, cefotaxime, cefotriaxone, and cefoperazone. They are active against gram-negative bacteria, including Pseudomonas. They are acid labile. They can be destroyed by HCl. I can't use them orally, only parenterally. They are beta-lactamase resistance. They can cross blood-brain barrier and reach effective concentration in cerebrospinal fluid, so I can use them in treatment of meningitis. Fourth generation looks like third generation with more activity against Pseudomonas and more resistant to beta-lactamase. Fourth generation include CVB. Remember, the only member of second generation that can cross blood-brain barrier and reach effective concentration in CSF is cefuroxime. Cefuroxime. It belongs to second generation. The only member in second generation that reach CSF in effective concentration. Cefuroxime. Uses of penicillin and cephalosporins. Urinary penicillin and cephalosporins or cephalosporins, both are right, used in treatment of urinary and lower respiratory tract infection. Upper respiratory tract infection as tonsillitis, pharyngitis, laryngitis. Lower respiratory tract infection as bronchitis, bronchopneumonia, and pneumonia. They also can be used in treatment of skin and soft tissue infection, otitis media, caused by susceptible organisms. Gram-negative bacterial meningitis, I can use penicillin and third or fourth generation cephalosporins. Intra-abdominal, pelvic, and brain abscess, I can use a combination of third generation cephalosporins and clindamycin or metronidazole. This combination for synergistic effect and decrease the side effect of both of them. Pseudomonal infection, I can use anti-pseudomonal penicillin and third or fourth generation of cephalosporins. I can use them in prophylaxis, surgical prophylaxis, third generation cephalosporins plus clindamycin or metronidazole, 24 hours preoperative, intraoperative, and 48 hours postoperative to prevention or for prophylaxis against a bacterial infection. I can use third generation cephalosporin for treatment of gonorrhea. Cefotriaxone is the first choice for treatment of gonorrhea, single injection. I can use them in treatment of bacterial endocarditis, penicillin G plus gentamicin or nafcillin plus gentamicin for Staphylococcus and Streptococcus endocarditis. And as I told you, this combination is beneficial for synergistic effect and decrease the side effect of both of them. I can use penicillin and cephalosporins for prophylaxis against bacterial endocarditis in patients with rheumatic heart valvular disease undergoing dental procedure. I give him intramuscular injection of procaine penicillin G 24 hours before any procedures. Side effects of penicillin and cephalosporins. Both are related to each other. Hypersensitivity reaction. Hypersensitivity type 1. Include skin rash, itching, fever, urticaria, or in the form of anaphylaxis. Anaphylaxis is very rare and occur mostly with parenteral penicillin. So skin sensitivity test is required before parenteral administration of penicillin. As you know from the first term, hypersensitivity reaction is type B bizarre adverse drug reaction. It is not dose related, but the manifestation of hypersensitivity reaction is dose related. This means hypersensitivity reaction occur independent of the dose, but the manifestation occur related to the dose. So the manifestation of low dose penicillin may be skin rash, itching, fever, urticaria. But when I give penicillin parenterally, this means large amount of penicillin reach circulation in short time, and this may lead to severe form of hypersensitivity reaction, which is anaphylactic shock. So I must do sensitivity test before parenteral administration of penicillin. Hypersensitivity reaction to penicillin are related to penicilloic acid. It is one of the metabolites of penicillin, which act as an incomplete antigen, hapten, that combined with tissue protein to form antigenic complex. And this antigenic complex will stimulate the immune system for production of antibodies, and these antibodies bind to the surface of mast cell, and on re-exposure to penicilloic acid, it will react with antibodies on the surface of mast cell, and this leads to rupture of mast cell and production of mediator of hypersensitivity reaction, histamine, prostaglandins. These mediators will produce the manifestation of hypersensitivity reaction, which include skin rash, itching, fever, urticaria, or anaphylactic shock. If this occurs, how can I treat it? How can I treat hypersensitivity reaction from penicillin? This is a question for you. Cross sensitivity exists between different penicillins and between penicillins and cephalosporins. In about 5 to 10% of penicillin allergic patients will be allergic to cephalosporins. There is a cross allergy between different Betalactam chemotherapeutic agents. So when one patient is sensitive to penicillin, I can't give him any Betalactam chemotherapeutic agent. Why? Because there is cross sensitivity between different type of Betalactam chemotherapeutic agents. GIT, penicillin and cephalosporins, especially broad spectrum penicillin and cephalosporins, can produce diarrhea and pseudomembranous colitis. Why? Due to superinfection. Broad spectrum penicillins and cephalosporins, as ampicillin and the third generation cephalosporins, will destroy different types of bacteria, most type of bacteria in our GIT, and gives a chance to other microorganisms to overgrowth. This means superinfection. This means superinfection with dead microorganisms. These microorganisms have the upper hand. This includes fungi and the other types of bacteria which can't be destroyed by broad spectrum penicillin or third generation cephalosporins, and this lead to diarrhea and pseudomembranous colitis. Dose-related and reversible nephrotoxicity with cephalosporins, and so I can't use them with loop diuretics and aminoglycosides due to increased incidence of nephrotoxicity. What are the drugs that cause nephrotoxicity? This is a question for you. Please collect them for me. What are the drugs that cause nephrotoxicity? You know, cephalosporins, diuretics, aminoglycosides. Neurotoxicity with high-dose penicillin. High-dose penicillin cause irritation of CNS. May be due to decrease GABA in CNS, and this may cause epileptic attack in epilepsy, in the patient with epilepsy. This neurotoxicity increase with very high dose of penicillin, and if I give the penicillin intrathecal in patient with meningitis, I should take care with patient that suffer from epilepsy. Cephalosporins may cause pain after intramuscular injection and thrombophlebitis after intravenous injection. That's why I combine cephalosporins with local anesthesia in one vial for intramuscular injection. Garish-Hergdheimer reaction. What's Garish-Hergdheimer reaction? Is very important. It is a febrile reaction after first injection of penicillin in treatment of syphilis. In treatment of syphilis, I use penicillin. After first injection of penicillin, the patient of syphilis may suffer from febrile reaction. This is due to death of bacteria, and this will subside within 48 hours. This means don't stop penicillin and I give only cortisone. This is not hypersensitivity reaction. This is only febrile reaction due to huge amount of dead bacteria in our blood or in the blood of the patient suffer from syphilis. I only stop penicillin in case of hypersensitivity reaction, but Garish-Hergdheimer reaction is a febrile reaction, not hypersensitivity reaction. I continue with penicillin, but I give cortisol to reduce this effect. So we finish penicillin and cephalosporins of beta-lactam chemotherapeutic agents. Beta-lactam include penicillin, cephalosporins, monobactam, and carbapenems. Monobactam, Asteriunam, it is one of the monobactams. It is resistant to most beta-lactamase, so I can use it treatment of beta-lactamase producing bacterial infection. It has narrow spectrum. It is only active against gram-negative bacteria. Very narrow spectrum. I can use it in treatment of gram-negative bacterial infection, especially in patients with allergy of penicillin. But it may cause super infection with staph and enterosudomonas colitis because it active against gram-negative bacilli, especially E. coli, Salmonella, Shigella. It gives a chance to staph and strep to overgrowth, gram-positive bacteria. And this will lead to diarrhea and pseudomembranous colitis. The last group of beta-lactam chemotherapeutic agent is Carbapenems. Imipenem is poorly absorbed from GIT, so I use it only parenterally. It has broad spectrum against gram-positive and gram-negative bacteria. It resists to most beta-lactamases. It is bactericidal as all chemotherapeutic agents which act on cell wall senses. It is rapidly inactivated by renin dehydropeptidases. Imipenem is used in combination with cystatin, which is renal dehydropeptidase inhibitor in a ratio of 1:1. I use cystatin to inhibit renal dehydropeptidase, which inactivate imipenem, and so imipenem will be prolonged duration of action, will be with the prolonged duration of action, and this is called combination. Why? Or explain. I use cystatin with imipenem because cystatin is a renal dehydropeptidase inhibitor, and this enzyme is responsible for inactivation of imipenem. When I use this combination, I get the chance to prolong the duration of action of imipenem. The combination is used in treatment of severe mixed infection because it is broad spectrum, active against the gram-positive and the gram-negative bacteria. The side effects of carbapenems include seizures, allergy, and GIT disturbance. Seizures, neurotoxicity. What are the drugs that cause CNS manifestation as a side effect? Yes, penicillin and the carbapenems. What are chemotherapeutic agents that cause neurotoxicity? Penicillin at high dose or when injected intrathecal, and carbapenems. We finish beta-lactam antibiotics. Beta-lactam antibiotics contain beta-lactam ring in their chemical structure. They include penicillins, cephalosporins, carbapenems, and monobactams. There are other inhibitors of cell wall senses. Beta-lactam chemotherapeutic agent act on the third step of cell wall senses. They inhibit the third step of cell wall senses. They inhibit the cross-linking between peptidoglycan layer, and so the cell wall become loose and easily destroyed. This is the third step, cross-linking. Other inhibitors of cell wall senses act on different steps. Vancomycin and teicoplanin act on the second step of cell wall senses. What's the second step of cell wall senses? It is the step of elongation of peptidoglycan, combination of D-alanine with N-methyl with N-acetyl muramic acid and the N-acetyl glucosamine. And after elongation, this peptidoglycan transfer across plasma membrane with a carrier outside plasma membrane and precipitated as a layer. This is the second step. The second step includes elongation of peptidoglycan layer and the transfer of this peptidoglycan layer outside plasma membrane. Vancomycin and teicoplanin and bacitracin act on the second step, act on inhibition of the second step of cell wall synthesis. They inhibit elongation of peptidoglycan layer and they inhibit the carrier that is responsible for transfer of this peptidoglycan layer outside the cell membrane. This is the mechanism of action of vancomycin, teicoplanin, and bacitracin. What's the side effect of vancomycin? It is very important. It includes allergy, ototoxicity, nephrotoxicity, and if rapid infusion cause histamine release, and this will cause vasodilatation of blood vessels and the patient become red. So it is called red man syndrome. It is very important. Vancomycin cause red man syndrome. What's red man syndrome? It is side effect when I inject vancomycin rapidly. It causes histamine release, vasodilatation of blood vessel, give the color of the skin, give red color to the skin. My skin become red, and this called red man syndrome. Redness occurs especially in the face and the neck. So I should inject vancomycin intravenous infusion, slowly intravenous infusion. Vancomycin not absorbed orally, but I can use it orally. If I use it orally, it means I need it for treatment of colitis. This is local effect. But when I need it to treat systemic infection, I inject it slowly by intravenous infusion. Uses of vancomycin: I use it for treatment of penicillinase staph and strep. This means vancomycin and the teicoplanin are penicillinase resistant. It is active against Pseudomonas. I can use vancomycin in treatment of methicillin resistant Staph aureus, MRSA, methicillin resistant Staph aureus. I use in treatment of staphylococcal infection. At first, penicillin, which is penicillinase resistant methicillin, and when resistance occurs to methicillin, I used vancomycin. When resistance occurs to methicillin, the bacteria produce a strain which is called methicillin resistant Staph aureus, and the scientists develop vancomycin to treat it. And this vancomycin, after a period of time, show resistance or either. Cycloserine. Cycloserine is one of the chemotherapeutic agents that used in treatment of TB, and it acts on the first step of cell wall synthesis. It inhibits D-alanine synthesis, and the dextroalanine is the first step in cell wall synthesis. cycloserine act by inhibition and incorporation of dextroalanine in peptidoglycan layer. The main side effect of cycloserine is CNS toxicity. So, what are the drugs or what are the chemotherapeutic agents that cause CNS toxicity? Yes, large dose of penicillin, or when I inject penicillin intrathecal, Carbapenems, and cycloserine. Betalactam, it inhibits cell wall synthesis by inhibition, the second step of cell wall synthesis, which is elongation of peptidoglycan layer and transfers of this peptidoglycan outside the plasma membrane. It is active against gram-positive and used topically in staph aureus infection. The main side effect of betalactam is renal toxicity. What are the drugs that cause nephrotoxicity? What are the chemotherapeutic agents that cause nephrotoxicity? Yes, penicillin, Cephalosporins, Betalactam, vancomycin. These are the chemotherapeutic agents that cause nephrotoxicity. Vancomycin also may produce ototoxicity. What are the other drugs that cause ototoxicity? Think. Yes, loop diuretics, aminoglycosides, and salicylates. So, in this lecture, we collect some drugs that cause nephrotoxicity, some drugs that cause ototoxicity, and some drugs that cause neurotoxicity. Please remember them. This is learning moment for you to remember what are generations of cephalosporins and to remember the other beta-lactam chemotherapeutic agents and side effects of both penicillin and cephalosporins, side effect of monobactam, side effect of carbapenems, side effect of vancomycin, what is red man syndrome, what is Garish-Harikdaimer reaction, what are the chemotherapeutic agents that cause nephrotoxicity, what are the chemotherapeutic agents that cause ototoxicity, what are the chemotherapeutic agents that cause neurotoxicity, what are the drugs or chemotherapeutic antibacterial agents that act on cell wall synthesis. Beta-lactam chemotherapeutic agent, which includes penicillin, cephalosporins, monobactam, carbapenems, and the other as vancomycin, teicoplanin, cycloserine, betalactam. These are 8 groups of drugs that act by inhibition of cell wall synthesis. These are 8 groups of chemotherapeutic agents that act by inhibition of bacterial wall synthesis. Remember, there are 3 steps for bacterial wall synthesis. First step is inhibited by cycloserine. Second step is inhibited by vancomycin, teicoplanin, and betalactam. Third step is inhibited by Betalactam chemotherapeutic agent, which include penicillins, Cephalosporins, Carbapenems, and Monobactam. Thank you.